today we're going to talk about allergies. We're going to talk about environmental allergies, allergic rhinitis. There's a lot going on under the title of allergies in general. It's why there's a whole subspecialty devoted to it. So today, what I wanted to talk about was allergic rhinitis, which is a very, very common thing we see in the peds clinic, general pediatrics clinic. If you have any questions about allergies, allergic rhinitis, environmental allergies, please feel free to drop in the comment section. I'll answer them the very best I can. If you have additional questions you'd like to talk about things related, such as food allergies, asthma, eczema. It is Allergy Asthma Awareness Month, and allergy, asthma, and eczema form what we call the atopic triad. These three guys like to hang out together. And so it's really hard to talk about one without talking about the others, but I'm just going to try to keep it to environmental allergies, allergic rhinitis for today. So if you just had to guess what parents bring their kids, particularly little kids, into the pediatrician for, you would probably say a cough and a runny nose, and you would be absolutely correct. That is a large percentage of what we see. But what parents don't realize is that not every cough and runny nose is an infection or something we need antibiotics for. Okay, lots and lots of children have allergic rhinitis, and that is, a constellation of symptoms that typically are in response to something in the environment that triggers an allergy in a kiddo. It can be just at certain points of the year, seasonal allergic rhinitis, typically spring and fall when things are blooming and pollinating, or we can have perennial or persistent allergic rhinitis, and those are kids who are typically having symptoms to things that are present all year long, typically in the house, like dust or pet dander or cockroach dander. It's a thing that happens. But it's something we see a lot in kids. All right, so how do we figure it out, first of all? Typically, a child will come see us, and one of the chief complaints is my child is always sick, or my child's been sick for weeks, or my child just always has a head cold. And we'll ask parents to tell me more about that. But tell me what you mean about, he always has a head cold or he's been sick for the last few weeks. And the parents will start to describe a specific number of symptoms. Very, very common. It's runny nose, stuffy nose, coughing, and that's the main core symptoms we'll see. Sometimes we'll hear about kind of red eyes or watery eyes. Sometimes we'll hear about the coughing or the throat clearing. But what I'm listening for is often what they're not saying. These kids will not have fevers, vomiting, diarrhea, rashes, other things we very, very commonly see with viral illnesses, okay? So I always tell my parents when they come in to talk to me, if you're coming to see me about stuffy runny nose, cough, plus minus maybe some ear pain or pressure, plus minus maybe a sore or scratchy throat, that sounds like allergies. And they are super, super common, okay? So what do I ask a parent about next? We always talk about the family history. And again, I told you it's hard to talk about one without talking about the other ones. I'll say, okay, does your child have a history of allergies, environmental allergies, seasonal allergies, or hay fever? And the parent will say no. And you'll say, okay, does your child or anyone else in the family have a history of asthma, childhood asthma, exercise-induced asthma, or needing an inhaler at any point in time? And the family might say, yeah. And the same thing goes for eczema, sensitive skin, dry skin, winter itch, or keratosis pilaris. And the parents will say yes or no. I ask these questions, I ask it so many different ways. I'll tell you really quickly. Families will answer the question that you ask them. This is a little bit directed more towards my medical students and other medical professionals or nurses or other allied health professionals that might be tuning in. And if you are, hi, I hope this is helpful. Parents and patients will answer the question that you ask them. So if you ask a parent, does anybody in your family have asthma, they'll tell you no. But when you ask them, okay, has anybody in your family ever have had wheezing or needed an inhaler? And they'll tell you, oh, my husband needs an inhaler whenever the pollen's up. Okay, that sounds like that. What that is allergy triggered asthma. That dad has two issues going on that definitely relate to what that child's seeing me about. But it's never been named as such for the family, so they don't know to answer it. So I actually ask the family and child history questions for each allergies, asthma, and eczema, but I give multiple common synonyms for these conditions. And anytime I hear a parent call it something new, I'll add it in to my list of questions for that particular illness or a particular condition. Okay. Allergies, asthma, and eczema form the atopic triad. All three of these guys like to hang out together, and they are highly heritable. So if a first degree family member has one of these conditions, it is an excellent chance that your child's going to have it, or your child's going to have one of the other two. All right. So Timmy comes in for a stuffy runny nose and some coughing. No other viral illness symptoms. Let me ask you, Timmy have any history of allergies, eczema, asthma? No. No to those for Timmy. Hey, how about brother, sister, mom, dad, anyone else in the family with allergies, environmental allergies, seasonal allergies, hay fever? Dad has hay fever. Okay. Anybody else in the family have a history of eczema, sensitive skin, dry skin, winter itch, or keratosis pilaris? Me and his dad both have terrible, terrible dry skin. It's something we really have to work on. Okay. Anybody in the family have a history of asthma, childhood asthma, exercise-induced asthma, or ever needing an inhaler? Well, nobody has asthma, but his older brother will need an inhaler when he gets sick, like in the winter times. That's viral triggered. That's a viral URI triggered asthma is what that sounds like. Okay, so we've got a characteristic review of symptoms, pertinent positives and negatives that suggest this child has allergic rhinitis. We've got a family history that strongly indicates a history of atopy or allergic conditions in the family. And then I go in for the physical exam. There are some very, very characteristic, what we call stigmata of allergic rhinitis. We'll see in kids and adults, who come in and we're considering allergies in these kids or these families. We will have what we refer to as allergic shiners, okay? That's the dark circles under the eye, maybe some puffiness under the eyes that has to do with dilation of the blood vessels under there. It's not because your 6-year-old staying up late at night worrying about bills and stuff like that. Okay, the dark circles under a kid's eyes, we call those allergic shiners. We can see those with allergies. It's what I buy all that makeup to put on under here for, so you can't see it. What else can we see? A lot of kids and adults will have a crease that goes from the inner corner of the eye to about 2/3 of the way across the eye. See a crease under the eye. We call that Denny Morgan lines. We see that in people with allergies. Very common allergic conjunctivitis, the itchy, watery red eyes we see. We talked about that back in the conjunctivitis talk, you might have remembered. We'll go ahead and we'll look in these children's ears. Ear pressure or pain can be or itchiness can be a symptom of allergies. And what we'll see typically is some fluid, very often just kind of a thin rim of clear fluid kind of collected towards the bottom behind the eardrum. We see that in kids due to eustachian tube dysfunction, swelling, impaired regulation of the draining of the fluid behind the ear, or sometimes we'll see a retracted eardrum. That's an eardrum that looks like it's been sucked back into the middle ear canal. Again, eustachian tube dysfunction, difficulties regulating pressure. We can see that in kids with allergic rhinitis. We'll tell kids to look up and we'll take a look in the nose, all right? Inside of the nose, you have structures called turbinates. People with allergic rhinitis can have very pale, boggy nasal turbinates, okay? That tissue is very congested in there. And when we have kids open their mouth, stick their tongue out. We look way in the back of that throat, that very back wall of the throat, what we call the posterior oropharynx. There can be a lot of what we call hyperplastic lymphoid tissue in the back of the throat, way in the back, and it looks like a cobblestone street. We call that creatively cobblestoning. And that is another telltale feature of allergic rhinitis in these kids. What else can we see? A lot of times these kids will be just sitting there with their mouths open to breathe because they can't breathe through their noses. And very often we'll see children have what we call an allergic facies, where their actual structure of their face is narrowed due to the anatomic changes that have taken place as they've tried to compensate for these issues, okay? Going back more to review of symptoms, parents will come in, they'll talk to you about, the really obvious stuff, stuffy runny nose and cough. And you can start asking them about things like, are you worried about their hearing? Some of those pressure issues or fluid issues can cause hearing issues. Is your kid a sniffer? Is he one of these kids that just sits here and sniffs all the time? Is your kid a throat clearer? Is your kid one of these? Or is your kid an itcher? One of these kids. I almost totally forgot about one of my favorite physical exam findings. You can see, if you look real close at a kid's nose, sometimes you can see a transverse crease across the nose. We call that the salute sign, from what we call the allergic salute from the kid rubbing their nose. I have a history of allergies. As a child, I had horrible allergies. And I was constantly the kid that was like rubbing at their nose, digging at their nose because it itched so bad all the time. A lot of these kids will also be rubbing their eyes or complaining of eye burning. It's stuff that, if you think about it, once I start bringing these up to parents, they'll be like, yes, he does do that. But honestly, I'm equally unsurprised if a parent says, no, he doesn't do any of those things. And when I look at that child, it is very clear that that child has all the physical exam findings associated with allergic rhinitis. I even one time had a child in clinic with her mom, I think like 5 or 6, and mom's, telling me about all her symptoms, and I go through the questions. Are we eye rubbers? Does she complain of, is she an eye rubber? Do her eyes burn? Do her ears itch? Is she a nose itcher? Is she a sniffer? And the mom's like, no, she doesn't do anything like that. I really didn't know what you're talking about. And no lie, this 6-year-old was like the whole visit. Sometimes you just don't hear it anymore. And it's, again, completely understandable when you're living with it day in, day out. So allergies, allergic rhinitis, extremely common in the population in general. Very common thing we encounter in the pediatric clinic. It is a very common cause behind one of our most common complaints, which is stuffy, runny nose and coughing. Kids with chronic cough, think about allergies. It's one of the top causes. And so let's say, what you're telling me, the review of systems, the chief complaint, the past medical history, the physical exam, this is all pointing towards allergic rhinitis. Parents will sometimes say to you, okay, well, how do we prove it's allergic rhinitis? And this is where we get into kind of the art of medicine versus, and experience and practicing medicine versus what you can just generally look up. Because I'll tell you, there are allergy tests out there. And I tried to tag some pediatric allergists. Dr. Patel, I tagged you. Please jump in and correct me if I get any of this stuff wrong, okay? Because I will tell you, through my experience, I've developed a policy that as a general pediatrician, I do not perform allergy tests. Allergists perform allergy tests. And I know I can order them as a general pediatrician, but based on my practice and the things I've seen in practice, I don't think it's a good idea for me as a general pediatrician to be ordering these tests. Okay, so why? So I will tell you that, again, allied professionals who are watching, if you order a test any test, a blood test or a throat swab, all the way up to advanced imaging, an MRA, fancy nuke med study, something like that. If you order that test, you are then responsible for dealing with the results. You do not order a test if you, A, don't know how it's going to change your management, or B, you don't feel comfortable managing the result of that test. Okay? There are blood tests and there are skin prick tests for allergies. Okay? As a pediatrician, I can order the blood test and do that in my office. Skin prick test, I can't. That has to be done in an allergist's office by specialized professionals. The blood test, there are some pros and cons for each of them. The blood test can be done when a child has really bad skin and it's hard to do the skin prick test on the child. If the child can't stop taking their antihistamines, things like that, that's when you would go with the blood test. There are an incredible number of blood tests you can order, so you got to know exactly what you are testing for. The skin prick test, again, actually correlates more closely with the symptoms. And we're going to talk about why that's important in a second. I have terrible itchy, watery eyes and terrible stuffy runny nose and sneezing in the spring and fall. Okay, where do you live? Okay, here are the things you're most likely allergic to. Now we do a skin prick test. You have to stop taking your medications for a specific period of time, usually like a week or so, maybe longer. Dr. Patel, tell me if I get it wrong, because I don't order this test. You do skin prick tests. You got to stop your allergens. You have to lay still and let somebody prick your skin. Might not be a good choice for some kids, or some kids can have such severe eczema, it might not be possible for them, or other skin conditions. And it has to be done in a specialist office because there is a chance of a severe allergic reaction to the allergens they're testing. So you have to do it in a very specialized place just in case that's a side effect. So there is testing. So why don't we test people? Wouldn't that be great? Let's test you. Let's find out exactly what you're allergic to, and then you'll avoid those things specifically, and then everything will be great. I definitely have had parents say to me, I want to know exactly what they're allergic to. That's definitely understandable, but honestly, it's not the most efficient way in my experience, and I'll tell you why. Again, I'll use myself as an example. I had horrendous allergies as a child. I went and got those pin prick tests done, and what I remember is that I was horrendously allergic to rabbits, according to the test. That's great. We didn't have rabbits. I didn't have any contact with rabbits, so it wasn't a super helpful test. I'll give you another one for the blood test, and we can talk about food allergies another time if people are interested. That definitely deserves its own time. As a pediatrician, I've had 2 kids, you can't make this stuff up, 2 kids on my patient panel who had gotten blood tests for food allergies. According to the blood test, both of these children were deathly allergic to peanuts, according to the blood test. Every year, I had to renew their EpiPen prescriptions and give them new allergy action plans for school, get all that stuff handled for them. Guess what? Each of these kids, unrelated, didn't know each other, I don't even think, guess what they each had for lunch every single day? If you said peanut butter sandwiches, you would be correct. What is the advantage of that testing if the results are not going to impact your management? So this is typically how I go about managing allergic rhinitis or presumed allergic rhinitis in general peds clinic. You give me a history that's consistent with it. You give me a physical exam that's consistent with it. I will recommend to parents to start empiric treatment with allergy medicine, okay? The vast majority of them are very safe, and you can even buy them over the counter most of the time. For children who are 2 or younger, there is some additional discussion about kids less than 2. Allergic rhinitis is not should be a consideration, but should also be up there with other things because there is a time, there's an exposure required to develop true allergic rhinitis. We could talk about that another time if you want to. That's starting to get into a little fuzzier territory and harder to express over a bigger talk about allergic rhinitis. But little kids, you typically start them on Zyrtec, okay, or another second generation oral antihistamine. Okay, second generation ones are typically not sedating, easy to get kids to take, and you can buy them over the counter. There's Zyrtec, there's Claritin, there's Allegra, and really it's 6 in one, half dozen in the other, whichever works best for the family. I typically defer to Zyrtec or Claritin because those are most often once a day dosing. Allegra is often twice a day, depending on which formulations we're talking about. So 2 and under, we're talking about an oral antihistamine as the first line. All right. Once we get up to 4, the first line monotherapy, if the kid is just going to be on one medication, is an intranasal corticosteroid like Flonase. There's a number of them. Flonase is the most common one. It seems to be the one pharmacies and hospitals like. You can pick it up over the counter. That is very, very effective in treating allergic rhinitis for kids 4 and up. Sometimes you'll get kids fighting you because they don't like the spray up their nose. Then I'll tell parents, just give them an oral antihistamine then. A second line monotherapy that the kid will take every day is better than a first line monotherapy that you cannot get the child to take, is typically the conversation I'll have with the parents. Okay, if the child isn't responding the way you want them to with a monotherapy, we can layer in things. Kids less than 2, there are cromolyn sprays you can use, and it's Nasonex is an intranasal that's approved down to 2. Flonase typically starts at 4, last time I checked. But pharmacies really fight you on it, evidently, because it's more expensive than Flonase. That's a little bit of hospital stuff for you there. And I haven't seen Nasonex available over the counter. But cromolyn, also known as, I believe, Nasocort, should be available over the counter. So we can layer therapy. We kind of talked about the first thing. A lot of kids start with the Flonase. You add in the Zyrtec. And there's one more medication we can prescribe kids as general pediatricians that they can't pick up over the counter, and that's Singulair. Now, there are recent studies that discuss using that medication with caution. More recent studies have linked Singulair with kind of anxiety, depression. The neuropsych side effects are more common with that medication than we previously thought they were. So that's now an added layer of teaching we give parents. If we need the Singulair, we can add it in, but please monitor your child and let us know if you're having any issues. And these 3 medications are on top of other things you can do, like nasal saline rinses. Again, if the kid won't let you give them Flonase, there's an excellent chance they're not going to let you spray like saline up their nose. But nasal saline is non-medical, and what it does is it rinses the nasal passages and gets out all those aeroallergens that have gotten in there, are settling into that mucosa, and are irritating that child. So that's something you can do. And then we talk about all the environmental things you can do in the house. We keep the pets out of the child's bedroom. We put in air filters. We can, put the mattress in a case. We can put the pillows in a case. We get rid of all the stuffed animals because they just hold on to dust and stuff like that. If things are really bad, you can talk about taking out the carpets and just having wood on the floors. Okay, there's lots of stuff we can do environmentally that does not require medication. There are non-medical things we can do to treat, like nasal sprays. And then there are 3 medications typically I, as a general pediatrician, have at my disposal to prescribe to a child to layer on to try to help them with their allergic rhinitis symptoms, because allergic rhinitis can be actually pretty debilitating for people who have who have really, really bad allergies. If you've got really bad allergic rhinitis, it can make your life miserable. All right. If I have a kiddo that has a really great story for allergic rhinitis and is not getting the level of relief they want with the medications I can prescribe to them, then absolutely I will send that child to see a pediatric allergist. Okay. The allergist can spend more time. They have more subtle questions. They can tease out information. They have more time in their appointments to take a more detailed thorough history. Did I miss something? It's possible. That's why they're specialists. And they have at their disposal medications that I don't. They can do the testing, interpret the testing, and then they can do immunotherapy or allergy shots. You might have heard of those before. And it's a long-term plan to decrease the body's response to these allergens. This is another place where pinprick testing comes in handy. It seems to be a little bit better at coordinating that. Dr. Patel, tell me if I'm wrong. But in my reading, what I understand, it's a little bit better at directing that therapy. Again, that's a thing that's done typically in a doctor's office, okay, due to the risk for anaphylaxis in response to these shots, okay? Allergists will often do it at their office. Sometimes the pediatrician can have the serum at their office and administer the shots in their clinic if that's more convenient for the family. It's something we always did at Pendleton. And it's something that works. I did that for years. From the time I was a kid to the time I was a late teenager. I got that medication done. And my allergies still can be an issue, but not as problematic as they were in the past. And again, I've had parents say to me, well, it's just allergies. I mean, really, does it, I don't really want to give my kid medicine. Do I have to? And I always put out to parents that, again, we talked about it, allergies can be very debilitating. But what some people don't realize is that kids won't sleep if they have really bad allergies. If you have really bad allergies, you basically can have, kid obstructive sleep apnea. You don't actually go into that restful, restorative sleep. And then you have a kid that is tired all day long at school. They can be very irritable. And it can even lead to behavior issues and weight issues. So this is something I'll talk to parents about as part of the review systems and general history taking for kids, not only kids who come in with allergy type symptoms, but for kids who have weight issues and for kids that have behavior or school issues. I'll actually go down this path and see if this is another thing that might not be addressed as we're continuing, to go through whatever other things we need to do for the weight and the behavior. But it's something I'll look for because it is severe allergies can cause weight and behavior and learning and just general attentiveness issues in kids if it's really bad. And a lot of parents don't know that. Okay, so sometimes, I will refer to allergy if parents just don't want to start the medication. I really feel it's a very safe and a most time efficient process for families if we just kind of start empiric treatment with the medication and see what kind of results we get with kind of close follow-up. We can do phone follow-up. You don't have to go in the office. You can do phone follow-up, things like that. But if a parent says, no, I really don't want to take medicine, I'd really rather go with a guided avoidance strategy, and then you refer them to allergy. No problem. No problem. And the last point I want to make before I start looking at comments, and thank you for the couple comments I've already seen pop up, is, I've had a couple parents ask me, what about honey? Can I feed my child honey and use that the same as kind of immunotherapy? Great question. I'm a huge fan of interfering with kids as little as humanly possible. I firmly practice in the tradition of allopathic medicine, but I'm also a minimalist, okay? I try to touch children as little as humanly possible. The more variables you introduce, the more opportunity is for something to go wrong. And so typically, so if it were possible to feed a child a tablespoon of local honey a day and get the same effect you get with a second generation oral antihistamine, or the same effect you'd get with immunotherapy in an allergist's office, I would be all about it. That would be great. Unfortunately, the scientific literature we do have on this topic, and people have done studies, say it's not helpful and it's not going to get you the same result you get from medications or actual in-office immunotherapy. The idea with the allergy shots you get in the allergist's office is we're going to give you a little bit more and a little bit more and a little bit more of this thing every time, and your body's eventually going to stop responding to it. You're going to be desensitized to the thing that causes the allergic reaction, okay? And that is a result of very specifically timed doses of medication with very specifically calibrated increasing doses of the offending substance. Okay, you can't calibrate raw local honey that same way. You can't control the amount of pollen, etc., that's going to be in the raw honey. So you can't do that same desensitization. And likewise, another fact I didn't realize till I had to go and look it up. The pollen that bees pick up and that's present in raw local honey is from flowering plants. It makes sense. Bees fly from flower to pollinate. So the pollen is typically from flowers. The flowers aren't really the ones causing the issue. It's trees and grass. And bees typically aren't flying to trees and grass to spread that pollen or get that pollen on them. Okay, bees go flower to flower. Flowers aren't typically the thing that's causing allergies. Trees and grasses are the pollen you would want if you were doing this. And tree and grass pollen is not found in local unfiltered honey in any sort of significant amount. So that's a bummer. I know a lot of parents are really interested in that. I've heard about it a number of times, but the scientific literature we have at this point in time does not back up using local honey as a treatment for environmental allergies, which is a bummer because I would go for any excuse that would let me buy more things from a small local business, and any excuse to eat more honey is good with me. So that's my in-office talk I give to parents on pediatric allergic rhinitis, typically environmental allergies. Again, if people would like to talk about food allergies, things like that, let me know. And it's definitely something we can talk about. Absolutely. Dr. Patel, if I got anything wrong, please let me know. Let's look at some questions, okay? Beth, hi Beth, says, can coughing at night be allergy related? Yeah, it can definitely be allergy related. Night coughing, you can get a lot of post-nasal drip with allergic rhinitis. And so if a kid's laying on his back and all of that junk is just kind of dripping back into his throat, absolutely you can get nighttime coughing with allergic rhinitis. Definitely. Thank you for that question. And Lorian, hi Lorian, asked, what's the youngest recommended age for an neti pot rinse? That's a really great question. You can do it as young as you want to, really. I would say the limiting factor would be the child's tolerance for it. I'm 40 and there's no way you could get me to use a neti pot. My husband, who is 41, loves his neti pot. He has horrific allergies. There are some kids who can do it without any sort of issue. There are some middle-aged professional people who won't touch one if you pay them to, like me. If you've got a really small child, there's no reason you can't use just kind of the nasal saline spray bottles. We recommend nasal saline irrigation for infants all the time, usually having to do with kind of trying to decongest those kids. Little babies, stuffy runny nose. The only thing you can do for the little kids is saline rinse and bulb suction. Okay, if you're worried your little guy has allergies and you know he's not going to tolerate that neti pot, you can't get him to stand still long enough, hold the position. You can always lay him on his back and irrigate his nasal passages with the spray bottles, the nasal saline spray bottles they sell at any drugstore. Okay, thank you for that question. Do essential oils help allergies? They do not. They do not, and honestly, they potentially could make it worse. If you're aerosolizing potentially irritating particles, that could make it worse. Again, I do love me some essential oils. I like it when things smell very nice. I have a diffuser over there. And I love nice smells, but it's not a treatment for allergic rhinitis and can potentially make it worse. Uh, Gabriel asks, when you give something like Zyrtec or Claritin that's 24 hours, what's the best time to give it? Would it be better to give closer to bedtime so their sleep is better? Great question. Okay, so the second generation oral antihistamines are supposed to be non-sedating. So I will tell parents, give it whenever you remember to. But I do have some parents worry, is it going to make them sleepier? If you're concerned about the sleepiness or potentially you're interested in using that to your advantage, give it an hour before bedtime and see how things go, definitely. And one of the good things about that is some children will actually have a paradoxical reaction to Benadryl, believe it or not. Benadryl is supposed to make you sleepy. Benadryl knocks me out cold. But there are some children who have a paradoxical reaction to Benadryl, meaning it actually like makes them super hyper. I've never heard of that happening with the second generation oral antihistamines. So yeah, if you're wondering when to give it, try giving it an hour before bed and see how things go. And that way you'll know in case it does make your child sleepy. If you're worried and you want to try it out, don't give it before school. That's totally fine. Okay? That's a great question. Okay, not seeing any more questions. Allergic rhinitis is super common. I can sign off if you guys don't have any additional questions. Don't forget, I'll always come back and answer your questions. So if you watch this later or you think of something later and you'd like to ask it, please feel free. I come back and check on these and I answer questions when I see new ones, no problem. And I'll drop, in the next day or so, I will drop the visual files that go along with my lecture. I always like to give you guys something to look at. I'm a very visual, picture-oriented person myself. So I will definitely make sure those go up on our Facebook page and our Instagram page. And if you guys don't have any additional questions, I love talking to you. Thank you for giving me the opportunity to talk to you. And I'm always interested in what you guys have to say, okay? Thanks a lot, and I hope you guys have a really great week, okay? Bye.